Hello and welcome. We have a very important show for you tonight. We're going to be talking about dementia, and specifically about dementia and Parkinson's disease. When we think as lay people about Parkinson's, I don't know that many of us think automatically of dementia, but it is something that goes along with Parkinson's disease, or PD, quite often. With me is a guest who's been on before. It's wonderful to have her back. Dr. Okeanis Vaou is with me. She is a neurologist at the Noran Neurological Clinic. She's a movement and sleep disorder specialist, and she has the title of the medical director of the Minnesota chapter of the American Parkinson's Disease Association. So welcome back.
Thank you very much. Thank you for having me.
This is kind of a tough topic for a lot of people, but so important to understand more. And I think with understanding, we have a sense of control and power in a sense. So I'm glad to go over this with you and learn from you tonight. What percentage of people, Dr. Vaou, do you think ultimately deal with dementia who have Parkinson's?
So that is a question a lot of patients want to know. And early stage Parkinson's disease, usually you shouldn't expect to have dementia. However, as the disease progresses, we see more and more patients get dementia, develop dementia, to the point where at the end stage, you may expect patients to have about up to 80% of the patients to have dementia. It has been estimated that around the age of 70 or 75, you have a higher chance of developing dementia for patients who have Parkinson's disease, almost by 20% more. And if you compare it to the non-Parkinson patient population, you see that they might have, patients with Parkinson have about 6 times the risk of developing dementia.
Really? I did not realize that. When people first come to you and you have to give them the diagnosis, or when you have determined it and give it to them, do they think dementia right away, or is that something that as they read and learn? And
that's usually the case. So initially when they come to the office, they're more concerned about their tremors and their motor symptoms. They have difficulties walking or moving. So dementia is not really on their mind. However, once they learn more about Parkinson's, then comes the question of dementia eventually.
It's such a tough duality, isn't it, to have to deal with, all of this. And there are so many things that go along with Parkinson's, and we talked about them in an earlier interview, but focusing on tonight, dementia, I also am wondering, is there any way to predict if 80% of people get it ultimately? Is there any way to predict you might be in the 20%?
We do know what type of patient might get dementia earlier. These would be the patients who are diagnosed with Parkinson's earlier, later in their life. Patients who have less tremor and more stiffness, or how we call rigidity, when they have more that akinetic type of Parkinson's disease, which is more the stiff and rigid type of Parkinson and not the one that has more tremor. Patients who are unsteady, they have more chance or higher risk of developing dementia eventually. So these are the patients that we see that we fear will get dementia earlier on in their stages of Parkinson's disease.
As a doctor, this is kind of a curious question, and maybe you handle it case by case, but do you like to let people know that this might be coming, or is that something you don't want to?
Well, that is a very, very difficult
call, I bet.
It is very difficult, especially if you see patients who are young, who have families, who are working, and they want to know if they have dementia and when will they get it. Usually there's a timeline that we say probably within 10, 15, or even 20 years down the road after the diagnosis, the initial diagnosis, is when you should start getting some signs of dementia. So early on, that's the fortunate part with Parkinson's disease. Early on, you shouldn't expect dementia. However, there are some mild changes. For example, there's a slowness in the thinking processing, which is not dementia per se, that patient can function and they can work, and it's just that they need more time to get from A to B. And that's one of the first things that they notice, is that they can no longer multitask as they used to when they didn't have Parkinson's disease.
And we're such a multitasking society now, aren't we?
Yeah.
You know, so many people fear Alzheimer's and know people with Alzheimer's. Is the dementia that we see with Parkinson's pretty similar?
No.
It is not. Okay.
It's a different type of dementia.
How do you differentiate?
Yeah, so it's good for people to know that there's not one dementia or one type of dementia. There's a lot of types, and even rare forms of dementia. So the characteristic pattern of dementia in Alzheimer's disease is predominantly memory. So people don't remember recent events. They have trouble remembering or registering facts of their daily life or conversations. So that usually is not the case with Parkinson's disease, whereas they usually develop more, like I said, the slow processing speed. They have some problems with judgment, what we call executive dysfunction, executive function problems. So is kind of like not being able to, knowing how to perform tasks or do things, simple things.
Kind of regular tasks
Regular tasks, or even complicated, of course in the beginning it's complicated things that they used to know how to do and not anymore. Operate a smartphone, for example, would be one example. Then these are more the Parkinsonian cognitive dysfunction and not so much the Alzheimer's. Apathy is another behavioral change you see in patients with dementia, with Parkinson's disease who have dementia, meaning that they just don't care. Not because they don't care, but that everything is blah, everything is the same to them.
Is that part of the depression that goes along with?
Not necessarily.
It can be a separate.
Because depression, you feel sad. Depression, there's emotion involved. With apathy, you just
you don't feel maybe.
You don't feel anything. It's empty. You don't have any motivation for anything.
So you could have, things are piling up here, but you could have apathy and depression.
Oh yeah.
With Parkinson's.
Oh yeah. And it's very difficult to distinguish between the two.
Right.
And also treat.
I once heard a doctor down at the Mayo Clinic say that men often exhibit depression via irritability, the feeling of tension and anger and short fuses. Would you agree, and could that be included with SAD, and can SAD and irritability in your eyes both go along with depression?
Correct. So depression can present as irritability, agitation, but also dementia can present the same way.
Right. So sometimes that's got to be
it's very challenging.
Tricky. I know we don't know the cause yet for dementia. We don't know the cause for Parkinson's. And this is an iffy question, but if our scientists, doctors can figure out a cause, does that then automatically mean that we're on to treatment at some point?
That's actually a very good question. At this point, we do know, obviously, that there's some form of mechanism that's causing Parkinson's disease and dementia in Parkinson's disease. If we could find the mechanism and what is the real cause of it, obviously, I think we could treat both Parkinson's and dementia. The same goes for Alzheimer's dementia or other types of dementias, because they don't all have the same mechanism of degeneration. But that's what we're basically looking for.
I read somewhere recently in kind of a non-medical article, but it was interesting. It said we have 60 billion cells in the brain. Does this sound accurate to you?
Yes, it does.
And now we're also reading about neuroplasticity and rewiring, sort of, or retraining our brain. Does that give hope in the Parkinson's world at all?
What we're more looking into right now is neuroprotection, because we want to protect those cells from deteriorating, because those dopaminergic cells from deteriorating. So we have to stop that mechanism, whatever it is,
which is causing the
degeneration of those cells. So, because even if you develop other pathways, like you said, through neuroplasticity, even those pathways will be eventually affected by whatever the process is.
So even though the number 60 billion sounds huge, pretty much all of those cells
will be eventually affected.
There's not just one part of the brain that's...
Well, initially there is, but again, in more advanced stages of Parkinson's, the whole brain is involved.
Okay. That's interesting. In a way, it would have been good to have a map of the brain here, or a photo of it to look at. Okay, so hope doesn't lie in neuroplasticity at the moment.
I would think it's more in neuroprotection at this point, yeah.
We are going to talk some about some of the exciting things that are going on in the world of treating people with Parkinson's. But first I want to ask them about some of the other Parkinson's dementia type diseases. Lewy Body Dementia. Tell us, sort of in a nutshell, what that disease is like for people.
So it's very similar to Parkinson's disease with dementia. So if you have someone who has Parkinson's disease, advanced Parkinson's disease with dementia, and someone with Lewy body dementia at a given time, it's very difficult to differentiate. However, going back into history, we see that patients with Lewy body dementia present a little bit differently initially. So the first thing that we see is dementia, whereas in Parkinson's disease, dementia comes later.
Right.
So that's the first thing we need to look at and really
So people would probably confuse Lewy body with Alzheimer's, I'm guessing. Or although they're different kind
and Parkinson's
of
disease, yeah, it's because they're all so much alike. It's very difficult for initially to distinguish the one with the other from the other. So in Lewy body dementia, you have that initial dementia that is it's present from when the patient comes in. The other thing that we need to look into the history is that fluctuation of the cognitive functions. The patient has these gaps where they're they're almost like someone else. So they're confused, and those gaps may last hours or days, and then they're back to their normal self, or without having any cognitive problems.
So that can be very puzzling for the patient and the family.
It can, yeah. And thirdly, one of the other criteria is having hallucinations, formed visual hallucinations, animals, people with colors, and they can describe them pretty nicely. And that distinguishes Parkinson's with dementia and Lewy body dementia. Now, to make things a little bit harder, patients with Lewy body dementia look like they have Parkinson's, because they do have Parkinsonian symptoms. They may have tremors, they may have the shuffling gait, they may fall, they may be slow with their movements, and they may also have muscle stiffness.
So, yeah, it would be very hard to know, wouldn't it? One thing I read, and I'm not sure it's true, but is that if you have Lewy body, your life expectancy is not very long.
Correct.
That is true.
Correct.
What would it be, kind of average?
The average prognosis for someone with Lewy body is roughly about 6 to 8 years, give or take. I mean, it could be a little bit longer, but with Parkinson's disease, it's definitely more than that.
Right. It can be up to 20 or
25, 30,
Right.
it depends, yeah.
Right. Yeah.
Yep.
So that's a big difference,
Yes.
isn't it?
Yes.
And then another kind of dementia that's in the Parkinson's family, I understand, frontotemporal dementia. How do you define that?
Yeah, so that's a different type, almost totally different type of dementia than the other two. It's almost like the young patient's dementia, because we see it more often under 65 years old, whereas all the other dementias we see above 65 years old,
Right.
most commonly. It may start as early as 27 years old.
This is not what Michael J. Fox has, is it?
Michael J. Fox has Parkinson's disease.
Right. So it's not this
No.
kind
No.
of, okay.
No. And it's actually, the presentation is not memory loss. We usually see changes in behavior. They may become disinhibited. They might start cracking inappropriate sexual jokes or comments and become rude, or cannot hold their social interactions anymore, or because they just don't, socially, it's almost asocial, don't fit in, because they don't filter, their inhibitions are almost lost, gone. Some people present differently. Some people present with language problems, such as not being able to, they have word finding difficulties. They lack fluency in their conversations. So it's a little different type of dementia.
Different.
And only a few of them would look like, some of them look like they have Parkinson's, but not quite.
Okay,
It's
very
different.
interesting.
It's a different disease.
I'm sure not too many people fall in this category, but I have read that a deficiency in the vitamin B12 can cause some symptoms of dementia. Is there any way people can, well, I guess you can get that tested, right? It's a blood test.
It is a blood test. Actually, it's the best dementia you can have because it's treatable.
It would be
it's
wonderful
reversible.
if that was, what a person found out.
So when patients come in with concerns of memory loss, dementia, one of the first things that we look at is secondary causes, such as vitamin B12 deficiency. Look at their thyroid function. Sometimes when that is higher or lower, it can lead to pseudo-dementia, meaning not the real dementia.
Okay.
So once you treat that part, you obviously return to baseline. Another dementia that we didn't talk about is what we call the multi-infarct dementia, which basically is small little strokes over time affecting the brain and causing dementia. Of course, that's not a reversible type of dementia, but if you do an MRI, a brain MRI, you can...
That would show up then.
You can understand what's going on.
And I do think there's, for many people, maybe most people, there's some comfort in having a diagnosis.
Always.
For whatever is going on.
It's not only
even
for
if it's
comfort.
not a good diagnosis. I mean, not something you want.
Yeah, it's not only for comfort. I think it's also good to know what's coming, what lies ahead.
And good for the family in general
to plan. And because like we just discussed, I mean, there's some conditions that you can live for 20, 30, 40 years, some that you live up to 5 or 6 years.
Right, so
there's
get to a
huge
doctor.
spectrum. Yeah.
And should people really think neurologists and bypass the general practitioner and the family doc and the
Usually their general
internist?
practitioners are pretty good in referring the patients to a
Are
neurologist.
they? Okay. Even out state where there may be not very many neurologists, are they?
I think if that doesn't happen, then the patient comes to, chooses to come to a neurologist, because like you said, they do want answers.
I would think it would be important to get to a specialist.
Mm-hmm.
Now, we've only got a few minutes left, but some exciting things going on. You were just telling me and filling me in. Last time you were here, you were sort of telling us there was stuff coming, and now tell us some about this new pill that can really make life so much easier for people with Parkinson's.
Well, there's a new medication out that it's not different as in the generic or the compound.
What it's made out of. Huh?
What it's made out of. It's just longer. It lasts longer.
And that in itself, though, is a huge thing, isn't it?
Yes,
for,
it has.
For a patient?
It has changed a lot of patients' lives, because instead of taking a medication for every 2 or 3 hours, they now can take it every 4 or 5 hours, and obviously that simplifies their life.
And the life of the people caring for them.
Mm-hmm.
I do some consulting
yeah.
at a nursing home, and we've been hearing people say that I've got to get my Parkinson's meds really within a certain amount of minutes. I mean, a tight window, and it's not always easy.
It's not very easy. You have to time it with food, because it shouldn't be taken with food. Otherwise, it's not absorbed as well. So it's very, very challenging, especially for patients who are living, they're young and they're working.
Right.
It's very, very challenging.
So this longer lasting levodopa sounds
it gives you more freedom.
really, really good.
Mm-hmm.
And some of the other things on the horizon, can you give us a little sneak preview?
Well,
or are they still under wraps?
They're still under wraps.
Okay.
There is a lot actually going on. One of what we will be seeing probably this year is a medication to treat hallucinations in patients with Parkinson's disease.
That will be important.
That would be important.
And of course for the family as well as the patient or the caregivers.
And we usually see hallucinations in patients who have Parkinson's and have started to have dementia. So going back to dementia. So, and there's a lot of patients with hallucinations and some of them are really bothered by these.
And do most people with hallucinations, I've not been around anybody that has them, do they want to act out their hallucination too? Is it a fear in your mind as well as something then you want to take care of physically?
So there's two different kinds of patients with Parkinson's have hallucinations. Usually they're visual, and they usually know what we say. They do have insight, so they know they're not real, and they're not bothered by them. And they usually go away when it's daylight, and it's like ghosts. They come when it's dark. But then the more demented someone is, the less insight they have. So, and then they become more complex. They're bothered by them. They can't distinguish reality from what's...
So at first, they may say, I'm just having a hallucination. I know it's not real.
Right.
Go back to sleep.
Yeah.
Right?
Yeah.
Okay.
Yeah.
That's
Or
really
I have some
interesting.
patients who say, I know this guy is standing behind you. I know that he's not real. Let's continue talking. So
interesting. But this new med will help reduce the amount of hallucinations
or treat them.
the
I haven't
severity?
tried it yet, so I can't really tell you much about it.
Okay. Well, we have about 3 minutes left, and we have quite a few resources that we want to give you. So let's do that, and then I want to come back with a question for the caregivers. But we're going to give you 4 resources right now, and I think they're all important in different ways. The first one is the Noran Neurological Clinic. It's in South Minneapolis. This is where Dr. Vaou works. You can learn more about that clinic and her work by going to noranclinic.com. It's a wonderful resource if you need anything in the field of neurology. I have a grandson going there, so that's a place you could learn more about her work too. You have a lovely website. Then secondly, the American Parkinson's Disease Association, for which Dr. Vaou is the medical director here in Minnesota. We have the website, which is apdaparkinson.org. And then I want to give you 2 phone numbers, and both of these are important and helpful. The national office number, 888-302-7762, and the Minnesota chapter in St. Paul, 651-241-8297. And then the Alzheimer's Association. I've done some shows on Alzheimer's. They also have a wonderful website that is www.alz.org/MNND for Minnesota, North Dakota. A lot of support groups there, and I'm sure there are a lot of support groups too via the American Parkinson's.
Yeah.
And I think support groups are wonderful. And then finally, another national organization, the National Parkinson Foundation, and their website is www.parkinsonmn.org for our Minnesota chapter. So lots of resources to lean on a bit. And just a final last question. If you are a caregiver of someone with Parkinson's, what do you think is the best thing you can do to take care of yourself?
That is a very good question, because most caregivers forget to do that.
Do they? I can imagine.
And they feel that they should be taking care of their spouse. Usually it's women, because most patients with Parkinson or dementia are men. But they should remember that they need help, they need the resources, and in order to take care of their loved one, it should be a multidisciplinary team to take care of their loved one.
And not doing it all, or should not try to do it all.
No,
right.
And they can't. And there's a point where they do understand that, but maybe it's too late for them, and they could have done it earlier.
And should do it earlier.
And should do it earlier, for sure, yeah.
Well, thank you so much for coming down and going over all this really important and challenging material. It's been great to see you and
really nice
work
to
with
see
you
you
again.
Yeah.
Thank you for being with us. I'll be back again next week. Until then, have a good week.